Good day. I'm Debbie DiGiulio, the Director of the American Psychological Association Office on Aging and former Chair of the National Coalition on Mental Health and Aging. On behalf of the National Coalition and the American Psychological Association, I would like to welcome you to the first in a series of webinars sponsored by the National Coalition and its member organizations. The purpose of these webinars is to build upon the momentum created by the annual Older Adult Mental Health Awareness Day that is sponsored by SAMHSA, the Administration for Community Living, and the Coalition. You can find a list of future webinars at the National Coalition's website, which is www.ncmha.org. So before we begin the webinar, a few logistics. All attendees have been placed on mute to minimize background noise. If you would like to submit a question or make a comment, please type it into the question pane on your control panel during the course of the webinar. If you see that someone has already asked the same question as you have, you can upvote that question rather than posting it again. And our presenter will respond to your questions as time allows during the Q&A period following the presentation. This webinar is being recorded and will be available cost-free to all registrants. A link to the video will be sent to all when it becomes available. Finally, please take a moment to complete a brief survey that will be sent to you after the webinar. Your input and feedback on this and future webinars are very much appreciated. Today, our topic is integrating mental health care for diverse older adults in primary care and non-traditional settings. I am so very pleased to introduce our presenter, Dr. Patricia Arion. Dr. Arion is a professor at the University of Washington in the Department of Psychiatry and Behavioral Sciences, Advancing Integrated Healthcare Solutions, or AIMS Center. She is a psychologist and an international expert in the recognition and treatment of depression and anxiety in underserved populations and older adults, and a clinical geropsychologist. So I would like to welcome Dr. Arion.
Thank you very much for that very nice introduction, Debbie, and welcome to the webinar. It's a pleasure to be here to talk about integrated care in older adult populations, as well as underrepresented minorities. So just to remind you, the webinar today, what I'm going to be covering is a little discussion about what integrated behavioral health care is and the different models that are out there, some of the standard challenges with these models that we face with older adults and ethnic minorities, cultural assessment and treatment best practices, and then a little bit about how to modify evidence-based assessment and treatment for your community. So let me start a little bit about me. I've had about 25 years of experience in implementing collaborative care through the AIMS Center. In fact, I was one of the original team of investigators for the IMPACT study, which is the original research project that informed collaborative care. I was the psychotherapy expert along with Mark Hagel and had been very much involved in the cultural redesign of problem-solving treatment, as well as informing the delivery of integrated care to underrepresented populations, underrepresented older adults. As Debbie pointed out, I am a specialist in geropsychology, and I've been working with underserved communities throughout my entire career. I also specialize in the modification of interventions for underrepresented populations, including older adults. And since moving to the University of Washington over the past 4 years, I've acquired some recent experience working with rural and frontier populations. So I may have quite a bit to say about that, working with that population. So what I'd like to do now is get to know you a little bit. And so first, I'd like to know how many of you are, what your professions are, and what you can do is just basically click on the options and we'll show you the results. We want to know where you work and whether or not you work with older adults, and do you provide mental health services. So go ahead and hopefully you all can see the webinar series poll. And are answering the questions. Okay, so we've gotten a number of responses already. Quite a few of you are psychologists. Many of you, 88% so far who've responded, work with older adults. There seems to be an equal proportion of people working in different practices such as primary care, private practice, aging services, and community mental health. Thank you very much for answering those questions. Oh, and I'm sorry for those of you who are physicians and peer counselors. We did not put that option there, but those are, obviously very important groups of people. Have you all seen me advance my next slide? All right, so basically, let me take a moment to define or give you a little bit of a history of integrated care. So the integration of, basically what integrated care is a means of integrating any kind of specialty service into non-specialty settings. So there are quite a few models of integrated care in settings other than primary care medicine, such as hospital settings, schools, juvenile justice, and the like. And the idea is to help increase access to specialty services. There are a variety of integrated care models that also integrate not just mental health, but other types of specialty care such as cardiac care. And there are also integrated care models that are the reverse of putting mental health services into non-specialty health settings. For instance, in people with psychosis, there are some very good models, and this is a population that actually doesn't make use of a lot of primary care medicine. However, they take medications, and by the nature of their illness have quite a few medical comorbidities. And these models actually integrate primary care medicine into specialty mental health. Now, in terms of integration into primary care medicine, some of the first models or the early roots of those integrated care programs are in geriatric health. And the reason why these models were developed is because older adults carry a lot of medical comorbidities. And so to manage mental health issues in an older adult population without having access to what kind of medical conditions do they have, what other medications they're in, is not really very good practice. The other reason why mental health care was integrated into geriatric medicine is because of the need for better coordination between providers. And historically, mental health services and medical services have been very poorly integrated. Primary care doctors have historically talked about the difficulty in finding their patients' mental health treatment, and that there almost seemed like there weren't enough psychologists or social workers available to take on the need. There's also the concern about things like transportation and stigma, so real access barriers that older adults and ethnic minorities face. That the idea of going to, say, for instance, where I used to work at UCSF was called the Langley Porter Psychiatric Institute, was unheard of and not something that a lot of older adults would be willing, or ethnic minorities would be willing to walk into for fear of the stigma associated with mental illness. Examples of some of the early models of integrated mental health care for older adults, for instance, one of the earlier models is Lifelong Medical, which is in Alameda County, and it's a federally qualified health center that began the idea of integrated care into primary care, and it was started by the Gray Panthers in the Berkeley area. And so it's still in existence, but it's a really nice, example of how to integrate care, and one of the first models of integrated care. These models tend to work best when you're implementing evidence-based treatments for mental health. As an example, I was involved in actually 2 studies of integrated care for late life mental illness. One was the IMPACT study, the other was the PRISME study. And one of the main differences between these 2 projects is that in the IMPACT study, we worked really closely with care managers, and I'll talk about what that looks like in a minute, to train them in evidence-based assessment and treatment, whereas in the PRISME study, really the only training in evidence-based treatment was for brief alcohol use intervention developed by Fred Blow, as well as algorithmic prescription of antidepressant medications. However, the psychotherapies were not monitored. There was no real true training. And we published a paper on the access and outcomes for ethnic minority older adults in the PRISME model, and found that without that kind of training and availability, that people were accessing care, but they weren't getting better. So what exactly, there are a lot of different kinds of integrated care models. I've talked about 2 so far, but if you go to this website on the bottom, which is the SAMHSA website, as well as the NIMH government topics website, you'll see that there is a lot of variability depending on what kind of services are available and where they're located. So the integrated care models that have the best evidence base are those that are fully co-located and integrated. And what that means is that the mental health staff are actually there, part of the primary care clinic, working very closely with primary care staff, and that all the interventions and the services are integrated into the workflow. There's also shared space, but different structures kind of models. This is one of the first models I was trained in when I was an intern at Bellevue Hospital. I worked in the geriatric outpatient unit, and mental health and geriatric health were actually 2 different clinics, but we shared the same desk staff, we shared the same waiting area, we were on the same floor. And so there were lots of opportunities for people to go back and forth, and primary care doctors to refer patients to us, for us to refer patients to primary care docs. And so it looked like it was all the same clinic. However, we had different charting systems, we had different billing systems, and we did have 1 weekly round meeting that we would do to talk about specific cases. There are also enhanced referral models where a social worker or somebody on the medical staff is charged with finding and linking older patients or ethnic minority patients to mental health services, and that these clinics have a really strong relationship with mental health clinics or community mental health. That's another level of integration. So what does the data say about integrated care for older adults? First off, we find that these models are actually really effective in reducing symptoms of mental health issues like depression and anxiety, and that those treatment gains are maintained at least 2 years out during the follow-up period after treatment stops. It also results in much better coordinated care. Patients, doctors, and care managers feel like they have a much more holistic approach to working with the patient. There isn't a lot of back and forth and trying to get information from one system of care to another. And so the treatment planning is actually very well coordinated. There are data to show that it can actually save costs. So there's been a couple of studies showing that, that if you integrate mental health services into primary care medicine for older adults, you'll actually see reductions in all health care costs, which is a really important thing to consider when these are older patients. We're following them for 2 years. You would expect that the healthcare costs would remain either stable or would increase over time. However, if you introduce mental health services into primary care settings, the actual costs of care are minimized. And there are also really good studies showing that 8 years out after treatment for depression through an integrated care model, that older adults are more likely to survive the consequences of chronic and acute illnesses. In other words, they're less likely to die. And overall, these models are very effective for increasing access and utilization of mental health services among people who are low income, as well as older adults who are ethnic minorities. So what are the necessary components of integrated care? So first off, all integrated care models really need to be patient-centric, which means that the patient is there and you as the care manager or you as the system are there to help support their decision-making process about how they want to manage their mental health. The primary care doctor is also very important, particularly in older adults from different cultures where the primary care doctor is sort of the god of the clinic. And in order for any mental health services to be viewed with value, to be seen as accessible, it needs to have the gold stamp from the primary care physician. Moreover, when you're working with older adults with chronic illnesses, the primary care physician needs to be there to help inform your treatment selection to help you figure out what's going on with the symptoms that you're seeing and so forth. And I'll talk about that under assessment. Family is very important too. If an older person or an older person of color still lives with their family or has significant supports, they will need to be integrated as well into treatment planning, or at least informed about what the treatment planning is. And there are obvious caveats to that, which I'll talk about later as well. And then there is the expert. So oftentimes, now this is not consistent across integrated care models, but in collaborative care, the doctor, the patient, and the care manager, which we'll talk about in a minute, always has access to a mental health expert, be that a psychiatrist or PhD psychologist who is an expert in geropsychology, or a pharmacist, or somebody who is really expert in, troubleshooting when treatment isn't working. Data tracking is also important. It's highly useful. Well, not just useful, but important to be checking to see whether or not treatment is actually effective for the patient, and if it isn't over a certain period of time, that you change the intervention that you're offering. And then critical to the success of all of this is the care coordinator, the person who is the link between the patient, the family, the primary care physician, and the mental health expert, and is the one doing all the monitoring of the patient. So what does the care manager do? Care manager does a comprehensive assessment after there's a screening done by either a primary care provider or a medical assistant, who identifies a patient perhaps through the PHQ-9 or the GDS as potentially having depression or anxiety. They then educate the patient about the model of care that they're going to be using, how often you're going to meet, what the symptoms of depression and anxiety are, the different treatments that are available in the clinic for them. They provide support, therapy, and so if the patient elects to utilize psychosocial treatments, that's the job of the care manager to provide. They do treatment tracking, as well as care coordination and case management. So it's a lot of work that this care manager does. So let me talk a little bit about assessment, okay? Because the assessment, the initial meeting with the patient is highly critical to coming up with the best treatment plan for them. So with assessment, you need to consider, particularly with an older adult and with ethnic minorities, the evaluation of not just mental health services, but mental health issues, but medical issues as well. So for instance, it's really important that your comprehensive assessment take into consideration issues of disability, what are the, do they have hearing challenges? Do they have vision challenges? Do they have physical disabilities? What supports they have around managing their medical health care, as well as conducting a cognitive assessment. Now, one thing I would like to say about cognitive assessments is that you can use with older ethnic minorities screens such as the Mini Mental Status Exam and the Montreal Cognitive Assessment tools. However, just keep in mind that these are simply screeners, and just because somebody passes the screen doesn't mean that they don't have a cognitive impairment. If you suspect through other communication with the family, communication with the patient, your own impression that somebody might be struggling with a cognitive impairment, it's really important to help that person get a more thorough assessment. Knowing what kind of medical conditions the patient has, as well as how well they're managing them, is very important for treatment planning. There's a number of chronic illnesses and acute illnesses that can contribute or make somebody look like they're depressed or anxious. For instance, thyroid disease, certain cancers, heart disease, lupus, MS, and diabetes are all correlated with depression symptoms. And just to give you an example of how important it is to address that, I'll give you an example of a case that I saw of a woman who, she was sandwich generation, basically in her 60s, mother was in her 80s. She had been referred to us for depression and anxiety. She had recently, had always had a difficult relationship with her mother. Her mother became difficult to care for, and so she had helped her move the patient had helped the mother move into a senior community, which the mother was not thrilled about, and gave her a lot of pretty heavy guilt trip about why she should be taking care of her and not warehousing her, even though it was a very lovely senior living community. And in doing the evaluation, it became very clear to me that she had chronic thyroid disease and had not been taking her medication. And the patient had been reporting that, you know, she'd had these lifelong challenges with her mother before, but for some reason she was having a much harder time dealing with the consequence of her mother's guilt around this, and was trying to figure out why that was. So obviously this is a case that I would normally think, wow, rich psychological information, current life stressor, you know, of course this would be valuable for psychotherapy. But the first thing I said to her is, like, it's really important that you start taking your thyroid medication every day, just the way the doctor just ordered, because it will help clarify for me how severely depressed you really are, versus that the symptoms you're experiencing are due to your uncontrolled thyroid disease. And of course, after she started taking it regularly, she felt much better, felt like she could handle the stresses that she was experiencing with her mother, thanked me for making her take her medication, and all was good. Now, of course, you don't want to just do a medical assessment. You want to also take a look at what kind of psychosocial resources patients have. So for instance, you want to know, like, what their community is like, what kind of activities do they engage in. It's really important as you're older that you engage in not just pleasant activities, but activities that are valuable, that challenge your brain. If they have, for instance, changes in their social network or in the level activity, it's important to ask too, is this something that is new, or is this something that's always been about who you are? So for instance, somebody who's never been physically active their whole life and has always had a small social circle, you know, but doesn't necessarily feel like that's any big difference to them and they're not missing it, you know, helps you kind of figure out that you don't necessarily need to target those areas in a treatment plan. And then, of course, the cultural context in which the older person is living, you know, very important to understand, you know, how long they've been living in this country, if they're an immigrant, what kind of challenges they're having as an older person living in this country, if they're also an immigrant. And sometimes it's not just about immigration status. Sometimes I've worked with older minorities who, for instance, their own parents were from another country. They grew up with a certain way of interacting with their elders, yet their children grew up with a different kind of cultural value, and that they themselves are starting to experience this feeling of, like, why don't my children value me the way that I valued my parents? And so it's very important to get at some of the cultural challenges they may be facing. And all of this, of course, leads to you coming up with a comprehensive action plan that would include things like, you know, what kind of needs do you need to meet? What needs are being met? What kind of treatment you're going to offer to the patient or suggest to the patient, and whether or not there needs to be any additional referral to specialty services outside of the primary care clinic. So context matters quite a bit. It is, if an older person is living or very close to their family or with a spouse, it's oftentimes very helpful to include them in the assessment. The way that I tend to do it is I meet with the patient first and I get a comprehensive history from them. I ask their permission to talk to whoever it was that brought them in. And of course, if they say, no, I don't want you to talk to my family members or to my spouse, that's fine, I won't. You know, however, if they feel, yeah, I think they would be useful for you to talk to them, then I'll bring in the significant others. I'll ask individually, I'll have the patient step out so that the other person can feel comfortable talking to me about their concerns. And then I bring the patient and the family member together to talk about the action plan that we're going to be developing. One thing too to be really aware of in terms of socialization with older adults is that there is a big difference between social trimming and isolation. For a long time, we used to assume that older people, by nature of being older, suffered from depression because family members, friends are either dying or moving away or becoming more disabled, and there's not enough opportunity to socialize. And while all of that is true, it doesn't necessarily mean it's such a bad thing. Laura Carstensen at Stanford University has done some really interesting work on this phenomenon called social trimming. When we're younger, we have a tendency to have a lot of friends. And sometimes we have friends because of the circumstances or the context in which we're living. As an example, if any of you have children, you probably have a lot of friends who also happen to be the parents of your children's friends. However, as you get older, you may find over time where you no longer having the same kind of similar interests and so forth. And so you start to decide, maybe I won't spend as much time with this person because we have nothing to say to each other, or we don't have a lot in common, or that person's really exhausting. And so what happens is that even though your social network becomes smaller, it becomes way deeper because the people that you're with are much more supportive of you. So when getting a sense of what a person's social network is like, it's very important to ask them how well supported they feel by that social network. And then finally, there are some really nice measures. There's one called the Camberwell Assessment of Needs Scale, or the CANE for the elderly. This is a tool that we've used quite a bit for case management purposes, where there's a comprehensive list of needs that are common in late life. And then the assessment includes whether or not the older person feels that they're being met, and whether or not they feel that they need to be met. So let's move on to best practices, because your assessment is going to inform this. So just know that there's a lot of very good evidence-based psychosocial treatments out there that have been designed or redesigned for primary care medicine. Problem-solving treatment, cognitive behavioral therapies, particularly behavioral activation, interpersonal therapy, and clinical case management have all been studied in the context of integrated primary care. However, the thing you need to consider before you select an intervention, and some of the things I've learned in trying to implement evidence-based practices in primary care, different kinds of primary care settings, is that the clinical context and workflow are really important, as is the consumer's context, in selecting which intervention you want to provide. So in terms of treatment selection, the things that you need to, and this gets into how you tailor interventions not only for your workflow or where you're working, but for the patient. You want to know, really take into consideration that a lot of integrated care clinics have very different structures and workflow processes. Some clinics are super busy and some aren't. Where your clinic is located in relation to where your patient is located, the time that you have to meet with the patient, as well as the time the patient has to meet with you, whether or not either of you have access to technology that could support the implementation of evidence-based practices, whether or not you have outreach resources that can facilitate supporting that, the community for the older person, as well as thinking about cultural nuances. And I'll talk about all of these. So first, before you overall select a treatment for that you would like to be offering to patients, you need to be really aware of how responsive it is to overall practice flow. One of the big things that I've learned about, for instance, problem-solving treatment is that it's a really burdensome intervention for the clinician to offer. There are 7 steps in the model, there's a lot of decision points, and so even though it's an intervention that could be provided within a 30-minute time frame, many clinicians have reported to me about how exhausting it is to do that 30 times a day with a patient. And so thinking about how you might be able to adapt that intervention to fit into your practice flow without eliminating the elements that are important, such as goal setting, decision making, and action planning are really important. And you can actually talk to treatment developers about some of these issues about how to fit these practices into the workflow. There are other things too, like are there aspects to the intervention that could be shared with, say, for instance, a medical assistant or an outreach worker, so that it can be supported, you know, with, so that you can have supports and reserve your time for sort of like critical issues. So for instance, psychoeducation, checking in on homework, doing PHQ-9s on patients could theoretically be done by other workers in the clinic who support you, so that you can focus your time on actual intervention work. In terms of location, one of the challenges we've had around that is that you know, if you're working with rural populations or frontier populations, it's very difficult for patients to come in to see you. And even in my experience in working with urban older adults, there are times a day that they don't feel comfortable going out. And I'll talk about that in a moment. There's also a lot of challenges to you know, being able to you know, for instance, take the bus to come see you. And even though they may live, you know, maybe 10 miles from the clinic, it might take them an hour and 10 minutes to get to you, and that's a lot of time. So people have played around with in-home strategies, and that can be very effective if you have the opportunity to do that. It doesn't always work if you're working in rural settings. You know, but you have to be aware that there are cultural welcoming practices with underrepresented minorities. It's not unusual for somebody to be welcoming you into their home and offering you food or maybe a little gift. And it's very important that all of the training you may have had about never accept gifts, that needs to be suspended, because it's actually very insulting for certain cultures to not accept the orange that they picked out specially for you, you know, because that you're coming into their home. Some older adults have issues with clutter, and not necessarily hoarding, but I have seen a lot of older patients who have had issues with, you know, just hanging on to things because they're a little worried that they may lose something important. And they'll oftentimes be very wary of wanting to have you come into their home for that very reason. So while on the one hand, it's really useful to go do a home visit, because you can get a sense of how bad it is, and there may be some strategies you can help them with in terms of arresting that clutter, but also be aware that they may return you down for a home visit, basically based on that you know, challenge. You also need to be sure that, you know, if you're going to meet with them in their home, that, you know, it's just you and them, or if there's somebody else around, that they're not there eavesdropping or listening, because privacy is really important. And then the time of day, this is something I had mentioned before about how some older people living in urban areas feel very uncomfortable coming to afternoon clinics. This goes out for you too. When I was at UCSF, we did quite a lot of work in Alameda County, and there were times of day where in some neighborhoods was very dicey for care managers and assessors to go to patients' homes because they were living in low poverty, high crime areas. And around, pretty much the lore was around 2 o'clock in the afternoon is when you should start packing up and going back to the university or your clinic, because it's just simply not safe for you to be out. Same thing for the patients, very hard for them to get out during those times of day as well. Sometimes you can arrange to have to meet people halfway. So for instance, meeting in libraries, meeting in coffee shops, but again, privacy is super important if you're going to be doing anything out of clinic. And then if you have no choice for, you know, whether it's regulatory issues that you're just simply not allowed to leave the clinic, or you don't have the time to, just be really mindful of the patient's time. Because appointment times are going to obviously vary by clinic. I've worked with some clinics where you have 45 minutes to meet with a patient. I've worked with other clinics when you've got barely 30, maybe 20 minutes to meet with the patient. And so this gets really challenging in implementing evidence-based practices. Most of the learning, I would say pretty much all of the learning-based therapies are based on this construct that you should see the patient at least every other week, ideally every week, and that's not always possible, right? And if you can't see them more than every other week, then you probably need to consider using other strategies such as case management, supportive therapy, or motivational interviewing that doesn't require this weekly check-in. However, there are ways to get around that. If you have other resources like technology or outreach workers, then you can actually use these learning-based therapies because you have the opportunity to do check-in without having to bring the patient into the clinic. So let me move on to technology. And just so you know, in many states, distance learning is billable. And so it's not billable for a lot, but it can be, you can at least recoup some of your costs if you offer distance services. Older, and don't be worried about, you know, the common law is that older people can't use technology and won't use technology, and that minority consumers don't have access to technology. They actually do, and the numbers of the percentage of older people owning things like smartphones or tablets and computers is actually growing exponentially. If you think about it, I've been using technology my entire adult life. I'm 57. In the next, 10 years, I'm going to be one of those older consumers that can actually use technology. So this is something that changes over time. However, you do have to take into consideration, and let me just back up a second too, that technology-based psychosocial interventions are actually very effective for older adults. There have been, and for minorities, there have been a number of studies showing that even telephone-based therapies are very effective. Technology-based visits or telemedicine is widely used in the VA system with rural populations. And two people, Namki Choi at, I think it's the University of Texas in Austin, has been able to show that older people can use Skype for doing problem-solving treatment and have very effective clinical outcomes. But things to be taken into consideration. For low-income populations, technology does tend to be shared. So oftentimes a family will have one iPhone or one cell phone or one computer, and sending messages or emails or texts to somebody on a shared phone, you have to be very careful with privacy. The technology does tend to be on the older side. So if you're going to recommend apps, you'd be very mindful that not everybody's going to have an iPhone 10. Sometimes tech is not very private. Even if you have a computer, it might be important to help older people figure out what kind of earphones or headphones they can utilize. In fact, that might be also a very helpful strategy for disabilities associated with hearing. And sometimes technology can be super confusing. So before you recommend using technology as a strategy to support an evidence-based psychosocial treatment, make sure they understand, they know how to use, or they know how to use that technology. You might have to spend some time with them at your initial visit, teaching them how to use, say, for instance, Skype, if they've never used it before, or some whatever secure service that you have access to. In the absence of technology, you can utilize, if it's available in your clinic, outreach services. So some promotoras, healthcare workers, and so forth, can actually support quite a few strategies so that you don't have to actually see the patient every week. They can do things such as, there's evidence to show that they can do action plan supporting, so they can check in on homework. They can do light aspects of evidence-based practices. So if a patient is stuck on a particular homework, they don't remember it, or they don't know exactly how to implement it, an outreach worker can be very helpful in helping explain that to them. They can also do some, PHQ-9 assessments to see how the person's doing. And they can also facilitate with an engagement strategy. So if you haven't seen, and this is not unusual with certain populations, if you haven't seen a patient for a while, you can send an outreach worker into the community and see whether or not, do they need help getting connected again, and so forth. So involving others, when you start to, and I'm going to be wrapping up for questions shortly, but when you are involving significant others, be really mindful about who you pick as supports. It's very important that you do an assessment when you're doing your assessment with an older person, you also do a safety assessment, because just because they're living with their family members doesn't mean they're being treated well. And you want to make sure that they're safe, and that anything that you share with the caregiver is something that is shareable. And so, you also want to be careful about who you pick as somebody to work with you on supporting a treatment plan. If they are a family member, but they're not really a caregiver, they're not really interacting with your patient that much, then it might be, it may not be worthwhile to actually have them involved in the treatment plan. But the way I have used caregivers in the past is very lightly. I won't share anything that the patient has told me not to share, but I will talk about, you know, for instance, in an action plan, do you think you could pick up your mom this day to take her to this appointment? Or I might support the older person or the minority person in communicating with their children or their caregiver about what their needs are and have them come into the room and discuss that. It's also useful sometimes if there's a mild memory impairment to educate the significant other in the strategies you're using to help the older patient recover from their mood symptoms. But it's very important if you see that there are issues of memory to involve them. Some cultures really value having the family be part of the clinic, part of the treatment. You know, group-based cultures, you know, where community is sort of valued more highly than the individual, you know, it will be often very important for you to make sure that you have the family involved. And then culture. Be very mindful about expectations about what certain cultures expect doctors to do. One of the big learnings that we had in working with the Chinese immigrant population is that, you know, the doctor is seen as somebody very knowledgeable. And if you use an evidence-based practice where you leave the decision up to the patient as to what strategies they should use, so for instance, that's key in problem-solving treatment, is once they set a goal, you basically say to the patient, so what do you think would help you reach that goal? And the reason why we do that is because in Western cultures or in our culture, if they don't pick the strategy and you pick it for them, you know, the patient's less likely to do it. However, if you say that to an older Chinese immigrant, they're going to look at you and wonder what medical school you went to that you can't tell them what they need to do with their problem. So what we've done is adapted the intervention, PST, for Asian immigrants by coming up with a list of strategies that could target certain goals and then involve the patient in selecting which one they want to utilize. Also, we've noticed that in certain older minority cultures that using terms like, you know, we need to increase your pleasant activities, or we need to get you out more, is actually not, you know, doesn't resonate very well. And instead, something like valued activities, giving back to the community, taking care of somebody, doing things that are generative, are actually much more, using terms like that are much more resonate much more with patients and older patients, and they'll be more likely to actually engage in those activities. When you're dealing with caregiver distress, particularly in like Latino populations, there is a cultural feeling that, you know, my parents took care of me, right? You know, then I should be giving back and take care of them. And so any suggestion that you need respite or you need to kind of spell off some of your duties onto somebody else is often met with a lot of resistance. However, what you can do to help people engage better in those strategies of taking time off and taking care of yourself is using language like, if you take a break, if you get some sleep, if you do something nice for yourself, you're just going to be better at taking care of your mom than if you were tired all the time. And so, you know, again, language and how you explain strategies are really important. And then selecting the therapeutic elements out of an intervention that makes the most sense culturally is very important. One of the big modifications we did at San Francisco General Hospital for Latino populations when we were implementing Ricardo Muñoz's CBT model is that, particularly in the older population, this idea that of separating thoughts from feelings was just not something that anybody resonated with. And so we actually minimized that part of CBT considerably, made it more of an afterthought for behavioral activation. In fact, a lot of people who've done CBT or studied CBT for older adults have found that CBT for older adults actually looks much more like behavioral activation, re-engagement, and valued activities than it does like CT, which is traditionally used with younger adults. And just in closing, before we have some questions, there are some very useful resources available to you if you want to learn more about integrated care models with older adults and ethnic minorities. There's the SAMHSA HRSA Center for Integrated Health Solutions, the SAMHSA AOA Aging and Behavioral Health Partnerships, and the National Coalition on Mental Health and Aging. And then also, just so that you know, if you're having, if you're wanting to find, like if you don't work in primary care, but you're wanting to find connections with integrated care models, you can probably find in your area which clinics are doing integrated care through the National Coalition on Aging, area agencies on aging, can be resources. Most federally qualified health centers have started the process of integrated mental health care. Some states have adopted that. For instance, Washington State and California have been very active in providing integrated mental health care and primary care medicine. And then finally, you can go to the Affordable Care Act website and find out where integration is happening. So some final thoughts. You know, I have lately been very enamored of Bruce Torpeda's work with children, where he has been, he himself has struggled with how do you get people to know when to use what evidence-based treatment. And basically what he's done is to distill all of the evidence-based treatments into their therapeutic elements, look for where there's overlap, and then has kind of created this strategy for training people in those elements rather than in the package. So that helps you understand that, you know, if you've got somebody with anxiety, you know, exposure type therapies or exposure elements are probably more effective than if you have somebody who's got depression and they're say anhedonic and they need to get out more and so forth. So thinking about these, rather than thinking about evidence-based therapies as packages, but actually as components of effective interventions, can help you select what kind of treatment or how you're going to put together a treatment plan for older adults. We've been in my center, which is the UW Alacrity Center. It's funded by the National Institute of Mental Health. Are studying the use of human-centered design to help redesign our evidence-based practices so that they're easier to deliver, they're less burdensome, and they allow clinicians the opportunity to be much more flexible and still maintain the integrity of the evidence-based practices in terms of what is being delivered. So with that, I thank you very much. It's time for questions and answers, and you feel free to reach out to me. This is my email address at the University of Washington. Thank you very much. And Debbie, just checking in. Are you getting questions?
We have a number of good questions. A number of people had asked the name and reference for the assessment referred to with the slide on assessment contact matters. I believe it's a CANE.
Yes, it's the Camberwell, so CAMBERWELL assessment of needs for the elderly scale.
Thank you. A second question is, does assessment ever include assessment of the caregiver's needs, or is it the caregiver only asked about the patient's status?
You know, that's a really awesome question. And yes, I think it's very important, particularly if you, you know, if this person is really involved as a caregiver, to get a sense of what their needs are. Because if you don't, you miss an opportunity to help support the caregiver. And caregiver distress is highly linked to elder abuse and you know, disabled adult abuse. And so, yes, you should absolutely assess their needs as well.
Okay. How does the client's experience of discrimination and stigma factor into assessment and choosing therapy?
Right. Yeah, so this is something that I'm trying to study. I have a project in Eastern Montana where we'll be working with Native American communities, and the issue of historical trauma has come up repeatedly. And it is challenging. I don't know that I have the best answer for that yet, but I certainly, you know, in doing an assessment, I mean, one of the challenges you have in primary care is that you don't have the same amount of time that you would have in a community mental health clinic. But for those of you who do work in private practice and community mental health, I think doing that thorough assessment of where did you grow up, what kind of challenges did you face, you know, growing up, you know, what are you, you know, do you have any concerns working on, you know, what's your perception about mental health, can be very enlightening in terms of how you will work with that person. If you're in primary care medicine, I hate to say this because it's, you know, very reductionistic, but you can use like the PTSD checklist to get a sense of whether or not they've been exposed to trauma. And that can help, you know, I mean, one of the challenges too is that when I've worked with older people who've grown up in low income and under-resourced communities is that it's pretty common to have been exposed to traumas. And the trick though is that not to just assume that because they've been exposed, they haven't already figured out how to deal with it, just to keep it in the back of your mind. If it is a prominent issue, they're still struggling with, you know, years of domestic violence or having been abused as a child, then that's going to inform your treatment selection. I don't know that many good primary care models for, you know, PTSD associated with long-term repeated trauma. That might be an avenue where you would want to have a good relationship with a community mental health clinic that actually specializes in working with that population, because the nature of integrated care models often is that you are offering treatment for not a very long period of time, and these are conditions that often require more than, you know, 8 weeks of care and some monitoring.
Okay. Another question. It seems like hearing is so important. It impacts social isolation, ability to interact in primary care and in mental health services. Are there any successful models for increasing awareness?
Yeah, you know, and the other thing too is that they're starting to find that hearing impairment impacts cognition, and that if you're not correcting for hearing, people are more likely to have significant cognitive impairment as they age. So it's an extremely and crucial thing to address. You know, obviously the best the best way to manage that is through good audiology, a good audiology assessment, and then working with the patient around utilizing hearing aids or hearing enhancement strategies, you know, such as microphones and that sort of thing. I think immediately for the patient, a big issue is that there's a lot of stigma about wearing hearing aids, and even the small ones that are hard to see are extremely expensive. And I'm not sure that all health plans cover them. So you're actually working with the much bigger ones where you can see them behind the ear. You know, believe it or not, sometimes my session with a person who has a hearing impairment is focused on how do you cover up the hearing aids, or how do we cope with the fact that you need, you know, these devices to help you with communication, but are embarrassed to wear them. So we come up with strategies to help them, you know, cope with the fact that they have this impairment. But one of the things I've been able to leverage lately is the fact that, you know, you really do need this. It can impact your cognition. There's a lot of solid research around that. And that generally gets everybody on board, because nobody wants to end their life with a cognitive impairment.
Okay. Is Skype considered HIPAA compliant? I thought another video conferencing program had to be used that was more secure.
Yes, you're right. There are other video conferencing programs that are way more secure than Skype. For instance, the one that we're using right now, Zoom, is HIPAA compliant. There are HIPAA compliant versions of Zoom. And then also Google, I think it's Google Hangouts and Google Meet. Actually, it's Google Meet that has the privacy controls, so that the only people who can you know, access the chat or the video conferencing are the people invited. So yes, definitely do your homework. Skype is, I think there's a business model of Skype that also allows for that, but you do, obviously, if you're going to be doing offering services that way, you're going to have to pay for it.
I have one or two more questions that I'll ask you, Dr. Ariane, but I want everybody to know if you've sent questions in, we will answer them later, post-webinar, because we might not have time. Do you have any information about psychologists in private practice doing home visits under Medicare or other insurance or fee that is separate from a palliative or home hospice?
In private practice, I've none. The only time I've seen that done is similar to how people have historically handled technology-based care, is that they charge the patient, and the patient it's up to them to do the billing. But I'm actually not familiar with any codes for private practitioners to do those home visits. Most of the home visit models that I've seen in place have been part of like federally qualified health centers, or in states where, you know, they're rural and there just isn't good access to a professional.
Okay, and the last question, is the discharge nurse the right person to get in touch with to get referrals?
That's a good question too. It depends on the discharge nurse and social worker. Because sometimes there's a discharge social worker. You know, what we've done in our group is that we don't just rely on sometimes if you've got somebody who's really knowledgeable and works a lot with older patients and knows the community well, they can be a really valuable resource. But area agencies on aging often have a list of resources that you can access, to get a sense of what resources are out there to support older adults, whether it's about disability, socialization, and so forth. And that tends to be where we've gone.
Okay, and a couple of people asked about references. We will get those to you. And I guess the last question before we say goodbye is, have you incorporated an ACE survey into geriatric assessment in primary care?
And you'll have to remind me of what ACE survey you're talking about, because there's a few different ways that ACE has been used, and
Yeah, okay, yeah. Maybe we'll have to answer that later then.
I think so, yeah. I mean, if you mean the sort of case management measure, I know San Francisco tried to implement it for their integrated care model for older adults, and I don't know how successful that was.
Okay.
That's not what we were talking about. I don't know. So.
Well, with 1 minute to spare, we would really like to thank you for doing this, Dr. Ariane. We so appreciate it. We'll get back to our other questions later, and stay tuned for more information about upcoming webinars that will be hosted by the National Coalition of Mental Health and Aging throughout the course and this year and the beginning of next. So thanks so much, everybody.
Thank you. Bye.
Bye.